Hi, my name is Joni Zahar, and I'm going to be presenting today on a patient that I saw. I'm representative of the Pain Management Service today, and we just received a consultation for this little baby who's now 6 months old with a gestational age of 27 weeks, so she's presently 3 months corrected. She's here with chronic lung disease. She's been mechanically ventilated as well as on long-term benzodiazepine, alpha agonists, and narcotic infusions since the time of her birth, both with difficulties with failed extubation as well as failure to wean without increased agitation, desaturations, and other symptoms of withdrawal like diarrhea as well. Her history of present illness presently, I'll include her main problem list. Her past medical history is significant for she was born with a prenatal diagnosis of right-sided congenital diaphragmatic hernia. She did have a repair at age 21 days of life, as well as during that time she was on VA ECMO. Her complications at the outside hospital also included failed extubation, as well as inability to wean from her sedative infusions. Her next problem is she also has a PDA, ASD, and a ventricular septal defect. All three of those have not been repaired. As a result of her chronic lung disease, she's also developed pulmonary hypertension. This was confirmed by a cardiac cath about a month ago. Her final problem is G-tube feeding tolerance, primarily because of inability to remain extubated. Her impression at this time, as part of our reason for consultation, is a failure to stay extubated and poor tolerance of her weaning. Let me allow you to understand a little bit more about her review of systems. Basically, I went through this with the family. From an HEENT standpoint, there's an association with hypothyroidism with congenital diaphragmatic hernia, and she has had the appropriate follow-up workup, and she has no signs of hypo or hyperthyroidism. She has had no history of sinusitis or otitis media. She does have dysmorphic facial features, of which she's had brain ultrasound as well as a fast brain MRI, which shows some degree of leukomalacia, which goes along with some developmental delay. Respiratory, she's had pneumonia at least 3 times. She's had 2 pneumothoraces, primarily on the left-sided lung. She's had 3 episodes of tracheitis, of which she grew out stenotrophomonas as well as serratia. From a cardiac perspective, she did end up with a cardiac catheterization a couple weeks ago. She does have an elevated pulmonary vascular resistance of at least greater than 3, confirming that she does have pulmonary hypertension and has been started on her sildenafil. She is always continually fed by a nasoduodenal or transpyloric feeding. She's not tolerated gastric feeds at this time. She has no issues with constipation or recurrent bowel obstruction. However, she has had some issues with diarrhea, which we've suspected when we've gone down on her sedation. Musculoskeletal, she does have a history of 2 clots that are presently in her left femoral deep vein and left femoral superficial vein, and the right upper extremity as well, that she's presently on anticoagulation for. Neurologic, she is developmental delayed. She does have symmetric facial movements. She does move all extremities. She has never had a seizure, but she has had some spells that were also contributing to possible related to weaning of her sedation. On her physical examination, she's less than 5% on both height, weight, and head circumference.
At least that wasn't a person, sorry.
Come on around here. Over here, okay. Just come on. Okay.
She is developmentally delayed. Neural pupils are equilibrium reactive. Respiratory, she does have decreased breath sounds on both sides. On her chest X-ray, it does confirm that she's hyperresonant and her diaphragms are flattened. She does have good pulses. She also continues to have a mild S1 murmur, as she still has a remainder ASD. Her abdomen is soft. She has a large, well-healed scar. She does not have any abdominal distension. She has good motor movement. She has no increased hypertonic movements, as well as she's had no abnormal movements or decrease in her tone. Her medications that she's presently on, she's on sildenafil, she's on diuretics to include Lasix, Diamox, she's on darbepoetin, and she's on iron supplementation. She's presently on infusions that include morphine at 0.05 milligram per kilo per hour, Precedex 1.2 mics per kilo per hour, and midazolam 0.05 milligram per kilo per hour. She can also get PRNs of Valium and morphine PRN for breakthrough for watts greater than 3. Overnight events, and in general, because we're being consulted, her watt scores have usually been greater than 3. We're presently going down on her clonidine first, or on her Precedex, and we're having some issues with her watts being greater than 3, as well as increased agitation, tachycardia, and some hypertension as well. On my differential diagnosis, on her failure to wean, can be one of 3 things. The first problem would be related to if this infant can tolerate the normal percent of benzo and narcotic wean. There's not a lot of literature on how fast to wean. We can go by 10% or 20%, and in the past it appears that we have moved by 20%. So that might be one of our issues, is the frequency of how often we've changed her infusion amounts. The next could be related to the frequency that we've changed her infusions, every 24 hours versus every 48 hours, and depending on different attendings, it looks like what we've documented, we've had changes on consistency on the frequency of how to decrease the sedation frequency. And then my third differential is the supposed changes in her sedation. She's had desaturations, agitation, some diarrhea, not as much as we had appeared that the team felt was related to in the most recent wean schedules that we've had. She does have a history of pulmonary hypertension that's also been associated with agitation, desaturation, and she's not at full dosing of sildenafil for that problem yet, which may not be all related to failure to wean from her sedation. So our following recommendations would include, and also important to say, she's been extubated now for 24 hours, and she's presently on non-invasive ventilation with good response, without apnea, without increased work of breathing. However, she does have had some desaturations overnight associated with what nursing has said is agitation, tachycardia, and she does respond to PRNs. PRNs primarily of morphine, and oftentimes we've still used intermittent Ativan. So the plan that I would like to address with the team would be to, since we've safely extubated at this point in time, is to convert one of 3 of her present infusions. We would like to try to convert her to oral on all 3, starting out first with the Precedex infusion, and we'd like to convert the Precedex to the clonidine. And the way we would do that for the dose that she's presently on for the Precedex, we would start 2 mics per kilo per dose and give that every 4 hours. If she has breakthrough, meaning tachycardia, agitation, with going down by 10% on the Precedex infusion, I will make recommendations that we can increase it to 3 mics per kilo per dose, but continue to give that every 4 hours. After the second dose of enteral clonidine, then to decrease the Precedex by 0.1 mics per kilo per hour until we're off of the Precedex infusion. Number 2, we can go ahead and we can try simultaneously going down on the narcotic and the benzodiazepine. However, since she's had a failure in her wean plan according to her history, what I'd prefer to do is continue with the conversion with the Precedex first. Next week, what I would like to do is then go ahead and start the morphine conversion from morphine to methadone, and we could probably try to see how she could do with a wean rest schedule, and perhaps after a week of going down on the morphine, then consider going down on the benzodiazepine. We will follow her progress daily. For her PRNs, she can have breakthrough doses of, or we can go back up on the Precedex at 0.1, or we can also, as I said earlier, we can consider going up on the clonidine to 3 mics per kilo per dose, Q4 hours. She's presently getting Ativan for breakthrough Versed transition, which we're not transitioning the Versed or the morphine at this time, but she can continue to receive those for possible breakthrough. The remainder of her medications should not have any interactions with the medications that we're presently prescribing. As far as further agitation, our recommendations would also include getting occupational therapy and physical therapy involved, just as adjunctive therapy. The other opportunity would be to check her comprehensive metabolic panels for her liver function test. If those are normal, then tomorrow we can add IV acetaminophen, and we can give that to her every 6 hours as well. And if you have any further questions, you can contact us through our extension. Thank you.